My challenge in the next 25 minutes is to really tell you a bit about innovation as it relates to hypertension, which is maybe a tired topic for many of you, but I want to show you that that may have changed, and then talk a bit about innovations in heart failure that you haven't yet heard about in some of the earlier talks, and then happy to take questions at the end. These are disclosures, some of which may be relevant to the content I'll present. There are really three objectives here. The first is to outline the need, because we certainly have a lot of antihypertensive therapy, for more effective antihypertensive treatments. I want to talk a bit about emerging pharmacologic strategies for management of hypertension with a focus on the opportunity that's presented by newer therapies that target RNA and have very long duration of action. And then I want to switch gears and talk a bit about heart failure management, and we'll focus on newer therapies for HFpEF, which overlap nicely with the hypertension region. So we'll get right into it, and I think the first question that you should all ask is, gosh, do we really need new drugs for hypertension? We certainly have many strategies available, and I think the problem is that despite available therapies, as you can see on the slide, there still remain about 1 billion prevalent cases of hypertension worldwide if we define it at a cut point of 140 millimeters of mercury. The prevalence is rising in the population, as you see in this now dated graph on the left of the slide, probably related to secular trends in our success with and improving outcomes in patients and extending longevity, but also related to secular trends you've heard about in the incidence of diabetes and obesity. I think we know that hypertension is still a huge contributor to the rates of cardiovascular death worldwide. It's the leading contributor to the incidence of heart failure, the greatest population attributable risk, and it's still a major contributor to disability-adjusted life years that really lengthen the aging that Dr. Fuster mentioned in our population. 10% of global healthcare expenditure is related to hypertension, and diabetes patients suffer disproportionately, as do patients with chronic kidney disease. And the problem is that despite an arsenal of therapies available to treat hypertension, only about 20% of patients in most global surveys are controlled to guideline-recommended targets, and we don't do any better in the US than we do elsewhere in the world. So why don't we do a good job with treatment of hypertension? Well, the first is that many patients don't access the healthcare system, and so we don't have an opportunity to diagnose them, and that is a social issue we must address. There's also a lack of education and awareness of the importance of hypertension in our patient communities, and there's another barrier to cross. As I mentioned, there's a failure to diagnose hypertension in the clinic. If you look at the number of ambulatory encounters in our healthcare system at Mass General Brigham, where there was an opportunity to measure a blood pressure, but that opportunity was not taken, it is an extraordinary number. And that means there's a lot of missed chances to augment any hypertensive therapy in many treatment settings. And then even when we see it, we don't treat it. There's always the concern about adding medications or augmenting doses, the complexity that introduces, the need for longitudinal follow-up and laboratory surveillance that intrudes. And so in general, it's much easier to ignore it, call it white coat hypertension, and then send the patient out and hope it goes away. So the final thing is, even when we prescribe the drugs to the patients, we know that many of them don't take them as they should. The number of pills our patients are on, particularly the elderly, is so large that adding additional pill burden is often a challenge and compounds the problem of treatment adherence. And then finally, there are a fraction of patients who, even with our therapies, are resistant to the available antihypertensive therapies. So I think there is an argument that we need a better approach, and maybe some of that will come in the form of new therapies. So what new therapies are available for treating hypertension? Well, I'm going to show you a few different classes that have come to light with new clinical trial evidence in the last year and a half. It's important to remember that, up to about the last 2 years, there hadn't been a new drug approved for the treatment of hypertension since 2007, but we now have a few drugs that are coming to light, some of which have been recently approved and others on the horizon. So this is really an important time of innovation in hypertension treatment, both on the pharmacologic side, where I'll focus, and on the device side, where you may hear more in later meetings. So we're going to talk about aminopeptidase A inhibitors. The paradigmatic drug there is faribistat, dual endothelin receptor antagonists like aprocitentan, aldosterone synthase inhibition, baxdrostat, lorundrostat are two examples, angiotensinogen inhibition, which is an RNA-targeted approach with zilebesiran, and then nonsteroidal mineralocorticoid receptor antagonist, finerenone. So this is a big agenda for a short conference, so I'm just going to give you a flavor of some of the most recent data, and we can pick up any topics that are of interest to you in the Q&A. So aminopeptidase A inhibition is a strategy that's been employed for treatment of hypertension on the premise that this central system, in which the enzyme APA is responsible for the conversion of angiotensin II to angiotensin III, which is an important potentiator of angiotensin II's hypertensive effects. So this is a brain-related pathway that's important in activating the hypotensive effects of angiotensin II. There are some preliminary data from the New Hope study that suggested that in obese hypertensives, if you gave an APA inhibitor, the drug crosses the blood-brain barrier and reduces blood pressure. And so there was systematic study then in a resistant hypertension population in the FRESH trial of patients with blood pressure between 140 and 180, despite 2 classes of medications. You can see the demographics of the population on the slide. And in that slide, the treatment of faribostat, a potent APA inhibitor, compared to placebo was no different. And this lack of treatment benefit, despite promising preliminary results and science, really has killed this drug class, and clinical development has been halted. So there's not much more to say, at least about this particular agent in trials. Another approach, though, that has had interest, you've heard a bit about the role of endothelin receptor antagonism in pulmonary hypertension. ETA and ETB receptor antagonists also have effects on systemic blood pressure. The early trials of ERA antagonists in hypertension were limited a bit by the effects on pulmonary edema, on volume retention. And so the thought was that balanced ETA and ETB receptor antagonism might be a more effective antihypertensive strategy with more tolerability. And indeed, aprocitentan is one such agent. It's been studied now in a hypertension trial of 730 patients with blood pressure that was uncontrolled despite 3 conventional agents called Precision. And in that trial, there was a signal of dose-related reduction in blood pressure with aprocitentan compared with placebo that endured over the full 24-hour interval in ambulatory blood pressure monitoring. So there is some impression of benefit here. Note the significant placebo response in this trial, and this is a theme that will recur, where you can see that patients in trials do tend to take their meds a little better, and we do see reductions in pressure from baseline. And so the incremental benefit of aprocitentan here is about 3 or 4 millimeters of mercury, which is statistically important, clinically important, but maybe not as dramatic as we would hope. And at the higher doses, there is still fluid retention and edema at the max dose, but nonetheless, the FDA has approved this drug for commercial use as of March of this year. Another class is the aldosterone synthase inhibition class, and as you know, aldosterone plays an important role in regulation of blood pressure. It's a key effector of the renin-angiotensin system, and we all know that for many of our patients with resistant hypertension, addition of a mineralocorticoid receptor antagonist like spironolactone is quite effective in augmenting blood pressure reductions over standard agents, perhaps because of residual hyperaldosteronism that is unattended with standard therapy. And so this is the early experience of baxdrostat, a potent aldosterone synthase inhibitor for treatment-resistant hypertension. This drug is quite specific for aldosterone synthase and does not interfere with the action of 11-beta hydroxylase, which is the key enzyme in cortisol metabolism that has a lot of homology to the aldosterone synthase, so a very specific aldosterone synthesis effect. And when you give an aldosterone synthesis inhibitor in this phase 2 BRIG hypertension trial, in patients with hypertension on 3 or more drugs, you can see, again, very nice stepped dose-related reductions in blood pressure, as you might expect with inhibition of this pathway. And this has really fueled more interest in this class of agents as strategies for augmentation of antihypertensive treatment. There's a second agent called lorundrostat that was studied in patients with uncontrolled hypertension, the majority of whom had suppressed plasma renin and elevated aldosterone levels. And when you looked at the placebo-corrected change in blood pressure with lorundrostat compared to placebo, there was an incremental reduction of 8 millimeters of mercury with the lorundrostat group, sort of very similar tolerability and efficacy profile to the baxdrostat data. But I think the story is not quite so simple, because if we look at the recent data that Dr. Bhatt presented now about 1.5 years ago at the ACC from the HALO trial, looking at now that same agent, baxdrostat, in an uncontrolled hypertension population, blood pressure more than 140 on either an ACE inhibitor or ARB, in addition to a diuretic or calcium channel blocker, there was a sort of this peculiar result, which is that the placebo group dropped by about 6 millimeters of mercury, and there wasn't much incremental blood pressure reduction in the baxdrostat group. Certainly a blood pressure reduction, but no incremental reduction once corrected for the placebo change, which was quite substantial in this trial. And I think the question here then becomes, is the Hawthorne effect of participation in the trial, where the placebo patients take their meds and have an unexpected blood pressure reduction from baseline that may then attenuate your opportunity to see a treatment benefit, is that playing a role? And then I think Dr. Butt also pointed out in that presentation that the adherence to treatment in the highest dose group was actually quite poor, with about a third of patients who had very low drug levels. And so perhaps that also confounded the effect. And indeed, if you looked at the effect in the adherent patients, those with detectable drug levels, you now saw the expected dose response with baxdrostat. And I think this data is compelling enough that the drug is moving on for further studies in adequately powered clinical outcome trials in phase 3. So what else can we do beyond inhibiting familiar parts of the renin-angiotensin system? Well, I think one of the things that all RAS inhibitors have in common that are commercially available is that they activate standard feedback pathways and that are inherent in the regulatory system that is the RAS system. And the feedback loop that is activated is to increase circulating levels of plasma renin. And the primary substrate for renin is angiotensinogen. And if you continue to have available angiotensinogen and renin levels rise, then over time, the treatment effects of many of these RAS inhibitors is overwhelmed and you have angiotensin escape. And so if we could deplete the substrate for renin, then even in the face of hyperreninemia, it's possible that we might maintain treatment effects or even augment them over time. And there are two approaches to suppression of hepatic angiotensinogen that have been explored. One is a GalNAc conjugated antisense oligonucleotide, and the other is a GalNAc conjugated small interfering RNA. So let me show you a bit about how these approaches differ. So we have two different approaches to silencing the message for angiotensinogen in the liver. One is to give a small interfering RNA. These are double-stranded oligonucleotide or DNA compound or RNA compounds that are taken up through an asialoglycoprotein receptor in the hepatocyte that recognizes this GalNAc moiety that is conjugated to the drug. The drug is taken up, dissociated by an enzyme into a guide and a passenger strand. The guide strand is an antisense strand for the target RNA that then binds the target RNA in combination with this RISC complex that then signals that this mRNA is due for degradation. So you then essentially degrade the mRNA that would otherwise be translated into the angiotensinogen protein. And then the other approach is an antisense oligo approach, where a single strand of oligonucleotide is taken up in the hepatocyte through a similar mechanism, binds the target RNA, activating a different degradation pathway through RNase H1, but essentially leads to the similar result. Now, I'm going to show you more about the RNA-based pathway because we have a bit more data there, although the preliminary data with the ASO is quite similar, although slightly lesser suppression of angiotensinogen and weekly dosing. So here's the preliminary data about from phase 1 with zilebesiran, the first agent in this class of small interfering RNAs targeting hepatic angiotensinogen. And what you can see is after administration of a single dose subcutaneously of zilebesiran, patients have dose-related reductions in angiotensinogen within 2 to 3 weeks. There is a 90% reduction from baseline. And that reduction in plasma angiotensinogen levels persists all the way out to about 6 months after a single dose. So this is now sustained suppression of angiotensin message with a single subcutaneous dose of a small interfering RNA targeting angiotensinogen. You can see the placebo response in purple above. So any dose here really exceeding about 100 milligrams achieved pretty effective reduction of more than 90% in plasma angiotensinogen. I will come back to the implications of that for safety in a moment, but what we do see is what you might expect, which is that with that reduction, we see dose-related reductions in blood pressure, and the proof of that is in this KARDIA-1 trial, which is now a prospective randomized trial of 400 patients with hypertension defined by ambulatory blood pressure monitoring who were washed out of their antihypertensives and then randomly assigned to placebo or escalating doses of subcutaneous zilebesiran. And you can see that with that dose-related suppression in angiotensinogen, there is dose-related reduction in ambulatory blood pressure as much as 12 millimeters of mercury compared with placebo in the peak group. And the blood pressure reductions, when we look at office blood pressures, as a least squared mean difference from placebo, are even more pronounced than they are in the ambulatory blood pressure data. We also see that much as with some of the agents I showed you before, this is an enduring effect and a consistent effect over the full 24-hour interval and even between visits. We know that in patients with hypertension, the volatility in blood pressure, that visit-to-visit or intra-visit variability in blood pressure, further contributes to cardiovascular risk. And so it might be the case, we don't know, that blunting that variability with more consistent blood pressure reduction, avoiding the extremes of blood pressure, the floating of blood pressure up and down, may actually translate into clinical benefits, but that's yet to be proven. And then more recently, we at ACC, we presented the data from this phase 2 trial of now zilebesiran as add-on therapy to patients with uncontrolled hypertension despite standard agents. And in this design, patients with uncontrolled blood pressure were washed out of their existing antihypertensives, randomized to one of 3 background treatment strategies in an open label fashion, a thiazide diuretic, indapamide, amlodipine, or a high dose of an angiotensin receptor blocker, 40 milligrams once daily. And that those that were taking their meds and who still had high blood pressure after the run-in period are then randomized to either placebo or zilebesiran 600 milligrams, one dose, and then followed for 3 and then out to 6 months. And in the 3 to 6 month interval, there was role for antihypertensive therapy to be added on. The primary endpoint here is measured at 3 months, and it's the change from baseline in ambulatory pressures. A number of other pressures were a number of other endpoints were examined, as was the frequency of adverse events. And what we can see in this experiment is that patients, regardless of background therapy, who were allocated to zilebesiran had important reductions that were incremental to placebo in systolic blood pressure at 3 months. And in most cases, these persisted to 6 months, even in the face of add-on therapy to treat residual blood pressure elevations. And these are pretty important blood pressure reductions. You can see compared to indapamide, 12 millimeter reduction, compared to amlodipine, a 10 millimeter reduction, and even against olmesartan, active in the same pathway, a potent ARB at maximal dose, an incremental 4 millimeters of reduction. And those changes in ambulatory blood pressure are amplified when you look at office blood pressure, which was reduced even more compellingly, even by 7 millimeters of mercury in the olmesartan group. So potent evidence that the addition of this angiotensinogen-targeted approach may augment the effects of standard antihypertensive therapies. Now, all of you are asking, do I really want an antihypertensive that acts for 6 months? What happens if the patient becomes septic or bleeds? And these are important questions to ask. The security we have is, in the preclinical experience at least, the effect of angiotensinogen inhibition can be rescued with standard pressor agents like angiotensin II or norepinephrine or other vasoconstrictors. The other issue is that high salt loads will also, as with other angiotensin or renin-angiotensin system inhibitors, will antagonize the treatment effect. And so it does appear possible to rescue the treatment effect in clinically important circumstances that would be expected. But fortunately, at least in these trials of relatively low-risk hypertension patients, we haven't seen a signal of serious adverse events. There are more adverse events in the zilebesiran-assigned patients compared to placebo, but very few cases of hypotension, though more in the zilebesiran-treated patients. Some excess of hyperkalemia defined at this treatment threshold. But in most cases, episodes of hypertension and hypotension and hyperkalemia resolved spontaneously and did not require intervention. And in fact, for the laboratory abnormalities, a second check of the number often yielded a normal result. There was also a subtle change in creatinine that was higher in zilebesiran-assigned patients. And so I think overall, the sense is that the safety profile is acceptable, but there is an excess of mild hypotension, hyperkalemia, and renal function, as you would expect with an agent active in the renin-angiotensin system that still needs to be attended in this treatment paradigm. So more to come. I think what we know at this point is that suppression of AGT using a GalNAc conjugated small interfering RNA is an effective strategy for lowering blood pressure, either alone or in combination with other medications. This approach has the opportunity and the advantage of a single dose with a very prolonged duration of action that might allow for biannual dosing of an antihypertensive agent for tonic background control on which you could layer additional antihypertensive therapy. And that opens the door potentially to office-based treatment of blood pressure on a periodic basis that would overcome some of the challenges with daily patient adherence to oral antihypertensive drugs. Although these trials are not yet powered or sufficiently long in duration to address long-term safety, the preliminary safety signals are reassuring, and there is an ongoing phase 2 trial called KARDIA-3 that will explore this treatment effect in a higher risk hypertension population, including patients with CKD, that'll yield some further evidence about safety, and then we look forward to outcomes trials to follow. So with that, I'm going to shift gears and talk a bit about the long-term consequence of hypertension, which is the development of heart failure. And I think amongst heart failure in hypertensive patients, the most prevalent form would be heart failure with preserved ejection fraction. You've already heard a bit from Mikhail and others today about how important this clinical problem is in patients with obesity. And I want to talk about the treatment strategies for this population and how they've evolved. I think this is a piece that we wrote in JACC Heart Failure of last year that was looking at the time at a synthesis of available data regarding treatment, and it's echoed in a JACC consensus panel statement that was released around the same time. And the concept is that we now know, based on 2 trials, DELIVER and EMPEROR Preserve, that SGLT2 inhibition is effective for treatment of these patients with symptomatic HFpEF, regardless of their symptom burden and regardless of their ejection fraction. We also know that exercise and weight reduction are valuable in this population for improving clinical outcomes, and so those are recommended for everybody, as are diuretics if patients are congested, but probably not if they are not. We have data from Paragon-HF that suggests that angiotensin receptor neprilysin inhibitors may be effective, particularly for patients with HFpEF and subnormal ejection fraction, less confidence about the higher end of EF. And then MRAs at the time, we knew had only data from the TOPCAT trial of spironolactone suggesting a signal of benefit with regard to prevention of heart failure hospitalizations, particularly amongst those patients randomized in North America, and that gave the US guidelines a 2B recommendation for use of MRAs. So that's as of last year. So since then, we have data now from a new approach, which is a non-steroidal mineralocorticoid receptor antagonist, finerenone, that has been studied in patients with hypertension, but also more prominently in 2 trials of patients with diabetes and proteinuria and chronic kidney disease. These are the Fidelio and Figaro trials, which showed a pretty potent signal of prevention of renal disease progression and also incident heart failure events in a DKD population. So we now extend these treatment effects to a heart failure with preserved EF population in fine arts. This is a randomized prospective trial, placebo-controlled, of finerenone in patients with heart failure and mildly reduced or preserved ejection fraction, defined at a cut point of 40%. You can see the exclusion criteria listed on the slide, which included recent use of an MRA. Patients had to have elevated natriuretic peptides. They had to have structural heart disease and use of diuretics in the 30 days prior to randomization. And so importantly, there were patients in hospital and recently hospitalized that were permitted to be included in this trial. So 6,000 patients validly randomized with a target dose of 40 milligrams depending on renal, or 20 milligrams depending on renal function. Primary endpoint, the composite of cardiovascular death and total heart failure events. I suspect you've seen these trial results, which are really quite impressive, that over the course of the 2.8-year follow-up of the trial, there was an important reduction of nearly 16% in the primary composite outcome with finerenone compared to placebo. That was highly significant. And this effect was driven primarily by an effect on total worsening heart failure events, heart failure hospitalization in particular. Now, that treatment effect was consistent across all of the subgroups examined in the trial, and importantly, in the subgroups defined by ejection fraction, which I'm showing you on this slide. So regardless of the EF 40 to 50, 50 to 60, more than 60, there seemed to be a consistent treatment effect. for all of the endpoints that were examined in the trial. That's distinct from the signal we saw in Paragon, but similar to the pattern seen in the SGLT2 inhibitor trials. And the other issue is that if we looked at the treatment effect as a function of background treatment with an SGLT2 inhibitor, again, no variation, suggesting that the effects of finerenone in HFpEF are additive to those of an SGLT2 inhibitor. And then if we pool this data then with what we already know from the prior trials of spironolactone, we start to see a pretty compelling signal that MRAs, and in this case finerenone in particular, seem to be effective for treatment of heart failure regardless of ejection fraction, certainly higher point estimates for benefit in the lower EF population than in the higher EF population, but nonetheless a compelling treatment benefit in HFpEF. And I think this may advance the recommendations in the next set of guidelines for recommendation of MRAs in this population in addition to SGLT2 inhibitors. So I think that moving forward, I think we've learned a little bit more about this. We know, I told you that patients in this trial could be enrolled in hospital or out of hospital, and the treatment effects in the recently hospitalized patients were pretty dramatic and maybe even more compelling than those in those without a recent hospitalization. And this is that treatment effect as a function of time from worsening heart failure shown in the slide for the primary and also for a key secondary composite outcome. And you can see that the absolute risk reductions are particularly pronounced in those patients enrolled in hospital or right after a hospitalization. And this may then be an important target for identifying patients who are suitable candidates for MRA treatment in clinical practice. I'm going to close with a brief note on a lifestyle modification and weight loss. You've already heard a lot about this, but just to remind you, we know that exercise and weight reduction are important in improving functional capacity in patients with heart failure and preserved ejection fraction, and we should be recommending it to all of our patients. But since weight loss is not always achievable in this population that may be functionally limited and in the ability to exercise, I think the strategies that Mikhail outlined for use of pharmacologic therapies to reduce weight are very exciting. And this is the data that he's already shown you from STEP-HFpEF and STEP-HFFDM, highlighting the effects of the weight loss dose of semaglutide on clinical outcomes, including functional capacity and quality of life in patients with HFpEF and the obesity phenotype. And I think we've heard the top-line data from Summit already mentioned that it met its primary endpoint, and we hope to see those data in a few weeks at the American Heart Association meetings. And so the conclusion here is that there are many new options emerging for treatment of both hypertension and heart failure. But we have a lot of work to do in implementing the therapies we have and deploying them effectively for our patients. These strategies targeting angiotensinogen that are RNA-based are exciting and offer an opportunity for overcoming some of the adherence barriers and maybe introducing a new paradigm for hypertension treatment that may simplify strategies for our patients if the drugs prove to be safe and effective in larger scale trials. I think you should walk away with the message that there is now guideline-directed medical therapy for HFpEF, much as there is for HFrEF, and that definitely begins with an SGLT2 inhibitor and may include a mineralocorticoid receptor antagonist, perhaps finerenone, and perhaps in the obese patients, a GLP-1 receptor agonist, in addition to an ARNI in selected patients and exercise and conditioning for all. And finally, the effect of MRAs in fine arts was additive to SGLT2 inhibitors, suggesting that we can't substitute the effects of one class with another, and it's really the comprehensive approach, slightly different from HFrEF, but similar in strategy that really matters in this population, and we must carry forward.